Welcome to our video on pulmonary aspiration, dyspnea, and hemoptysis. Let's begin. Here's an overview slide of the topics we'll discuss in this lecture. Let's begin with pulmonary aspiration. In this section, we'll discuss definition, risk factors, clinical presentation, diagnosis, and treatment of pulmonary aspiration. Pulmonary aspiration is defined as the inhalation of foreign bodies, oropharyngeal contents or gastric contents, into the larynx and lower respiratory tract. Some of the factors that increase the risk of pulmonary aspiration include settings of impaired consciousness such as seizures, traumatic brain injury, alcohol intoxication, or usage of sedating drugs, which can compromise the cough reflex and glottic closure. Extubation that removes ventilation or gastric tube is another risk factor. Esophageal disorders like achalasia and gastroesophageal reflux disease can also precipitate pulmonary aspiration. Patients under anesthesia are predisposed to pulmonary aspiration due to the residual effect of anesthetic that impairs laryngeal reflexes. Individuals with neuromuscular diseases are at increased risk of aspiration due to the loss of control over the pharyngeal muscles. The clinical presentation is generally variable. Patients may initially be asymptomatic but later develop respiratory dysfunction with cough, shortness of breath, and tachypnea. Before we move on, let's discuss a bit of the difference between aspiration pneumonia and aspiration pneumonitis. They are both complications of pulmonary aspiration. The difference is that aspiration pneumonia is primarily an infectious process in the lung due to inhalation of oropharyngeal bacteria, whereas pneumonitis is primarily an inflammatory process due to aspiration of sterile gastric contents. Although inflammation occurs in both cases, the trigger for the pneumonitis is direct chemical injury to the lung by gastric contents, whereas in aspiration pneumonia, there is inflammation eventually, but takes slightly longer because the body has to recognize the antigens and then mount a response. Pulmonary aspiration is diagnosed using imaging studies, specifically chest X-ray. The X-ray can, for example, show features of atelectasis or abscess. Atelectasis is complete or partial collapse of the lung. Pulmonary abscess due to aspiration of infective material are usually found on the right lung since the right main bronchus follows a straight path downward. Here's a chest X-ray showing an antero-posterior view. The radiologic finding shows infiltrates in the right lower lung, which may result from aspiration pneumonia. The right lung is most often involved since the right main bronchus follows a straighter path downward. How can aspiration pneumonitis and aspiration pneumonia be differentiated on chest X-ray? Both aspiration pneumonitis and pneumonia involve inflammation and hence show infiltrates on the chest X-ray. However, as we discussed, aspiration pneumonitis will show infiltrates acutely, whereas aspiration pneumonia may take longer to show the infiltrates. Also, in aspiration pneumonia, the chest X-ray may also show progressive consolidation and pleural effusion as a result of the acute inflammatory process. Hence, these two conditions can be distinguished by the onset of infiltrates on chest X-ray as well as consolidation and pleural effusion in the case of aspiration pneumonia. Coming to management, we should maintain airway, breathing, and circulation with supplemental oxygen and supportive measures. These include intravenous fluid infusions or advanced airway management such as intubation. If there is suspicion of aspiration pneumonia, antibiotics with anaerobic bacteria coverage such as clindamycin should be started. For patients who are at high risk for aspiration, we should keep the patient's head elevated. Let's discuss dyspnea. In this section, we'll be discussing definition, etiology, clinical presentation, diagnosis, and treatment of dyspnea. Dyspnea is defined as difficulty breathing. Based on the onset, dyspnea can be acute and chronic. Let's talk about etiology. Dyspnea can be due to cardiovascular causes such as heart failure, pericarditis, and arrhythmia. Pulmonary causes include COPD, asthma, pneumonia, and pneumothorax. Another etiology of dyspnea is chest wall abnormalities like kyphoscoliosis or rib fracture. Neuromuscular diseases that weaken respiratory muscles such as muscular dystrophy are also an important cause of dyspnea. Systemic causes may include severe chronic anemia or sepsis. Finally, panic attack and anxiety disorders are also included in the etiology of dyspnea. This table summarizes the various conditions which may lead to acute and chronic dyspnea. Acute dyspnea results from several disorders like myocardial infarction, aortic dissection, pulmonary emboli, pneumonia, arrhythmia, and pneumothorax. And chronic dyspnea also results from disorders like decompensated heart failure, aortic stenosis, anemia, arrhythmia, asthma, and chronic obstructive pulmonary disease. The clinical presentation varies a lot depending on the underlying cause of dyspnea. Some of the clinical features associated with dyspnea involve a sense of chest tightness, rapid breathing or tachypnea, excess breathing or hyperpnea, and palpitations. It can also be associated with orthopnea, cyanosis, and crackles. Orthopnea is difficulty breathing when lying flat. The discoloration of skin due to low oxygen saturation results in cyanosis. Crackles are sounds like an irregular, intermittent rattling heard on long auscultation. Diagnosis starts with a detailed history taking, where the examiner looks for specific risk factors such as history of smoking, repeated infections, or occupational exposure. Additionally, the physical exam can reveal important findings. On pulse oximetry, a saturation below 94% is considered hypoxic until proven otherwise. However, it is important to note that patients with COPD have chronically low oxygen saturation, typically around 88 to 92%, and only levels below this threshold are considered hypoxia. Laboratory investigations include an arterial blood gas if oxygen saturation is low on pulse oximetry or if hypercapnia is suspected, as well as complete blood count to evaluate for anemia, infection, or sepsis. For example, if the patient is anemic, they will have a decrease in the red blood cell count, hemoglobin, and hematocrit, whereas a patient with an infection or sepsis will have an elevated leukocyte count. ECG may show evidence of a cardiovascular cause of dyspnea, such as arrhythmias or ischemic heart disease. Imaging studies that can be done include a chest X-ray or CT scan. A chest X-ray can reveal pneumothorax, pleural effusion, pulmonary vascular congestion secondary to heart failure, or infiltrates due to pneumonia. A CT scan is more detailed than a chest X-ray and may show scarring of the lungs, which may occur in cases of interstitial lung disease, for example. Here's a chest X-ray revealing pneumothorax. As we can see, there's a large shadow here which shows the lung tissue collapse. Since dyspnea is a symptom secondary to an underlying pathology, it is important to treat the underlying cause. Intubation and mechanical ventilation are indicated if respiratory failure is imminent. 2 patients in a rural emergency department present with complaints of difficulty breathing. Patient A is diagnosed with a pneumothorax, and patient B is diagnosed with congestive heart failure. What differences in clinical presentation would be expected in these 2 patients? To systematically cover the differences, we'll use the mnemonic OPQRST, and we will compare using the OPQRT letters. O, onset. A pneumothorax is going to be of acute onset, while congestive heart failure can have acute exacerbations, but it generally presents as a difficulty breathing that develops over weeks to months. P, provocation. This one will be somewhat similar due to both likely becoming worse with exertion, but congestive heart failure will have the added element of orthopnea. Q, quality. The patient with pneumothorax may describe a sharp pain at onset, which is unlikely for congestive heart failure. R, radiation. Since dyspnea is not really pain, it's difficult to characterize it radiating anywhere, so we'll discuss associated symptoms. The patient with the pneumothorax may have had a trauma or an underlying connective tissue disorder. Congestive heart failure patients will likely have lower extremity edema, jugular venous distension, and cardiac risk factors. T, timing. A patient with pneumothorax, as said before, may have recent trauma or illness that causes the lung to be susceptible to collapsing, and it may be idiopathic. For the patient with congestive heart failure, they will likely describe a gradually increased difficulty breathing with exertion for a period of time, followed by difficulty breathing at rest and when laying down. As we are done with dyspnea, let's discuss hemoptysis. In this section, we'll discuss definition, etiology, clinical presentation, diagnosis, and treatment of hemoptysis. Hemoptysis is defined as the expectoration of blood or blood-stained mucus from the larynx, bronchi, or lungs. The primary danger with hemoptysis is choking, not blood loss. Hemoptysis is massive if the blood loss is greater than 300 milliliters and should be addressed immediately because it is life-threatening. Let's discuss etiology. Hemoptysis has many causes, including infections such as bronchiectasis, tuberculosis, pneumonia, and aspergilloma. Hemoptysis can be caused by direct trauma or local inflammation from an inhaled foreign body or fistula formation between a blood vessel and the tracheobronchial tree. Pulmonary vascular disorders with elevated pulmonary capillary pressure, such as pulmonary embolism or complications of mitral stenosis, can also cause hemoptysis. Lung cancers, especially bronchogenic carcinoma, which is a cancer of the bronchial lining, cause hemoptysis. Goodpasture syndrome, which is an anti-glomerular basement membrane disease, can lead to hemoptysis. Also, bleeding disorders like thrombocytopenia, disseminated intravascular coagulation, and use of anticoagulant or antiplatelet medications may cause episodes of hemoptysis. Here's a specimen of the lung of a patient with Goodpasture syndrome. It is an autoimmune disease, also called anti-glomerular basement membrane disease, that causes inflammation of these small blood vessels in the kidneys and lungs, which cause bleeding. Since the vessels in the lungs are affected, the patient coughs up blood. We can clearly see the diffuse bilateral hemorrhages in the areas of the white patches. The main presenting symptom is coughing up or vomiting blood. Other clinical features depend on the underlying cause. For example, cachexia, clubbing, fever, tachypnea, or hypoxia. Clubbing can be seen in bronchiectasis and lung cancer. Fever is seen in infections like pneumonia. The first step in the diagnostic approach is taking a good history. For example, history of repeated small hemoptysis is suggestive of lung cancer. Also, if the patient has blood in their urine, it may be an underlying pathology such as Goodpasture syndrome. The blood originating from the digestive tract will appear dark brown compared to hemoptysis, which appears bright red. A thorough physical exam by palpation, percussion, and auscultation helps to make a preliminary diagnosis. Laboratory studies include complete blood count with basic metabolic panel. A chest X-ray to determine the underlying pathology is mandatory in all patients with hemoptysis. Consolidation and patchy opacities can be seen in an abnormal chest X-ray. A computed tomography pulmonary angiogram may be performed to complement the bronchoscopy and detect the cause. Fiber optic bronchoscopy should be performed if there is a significant clinical suspicion for lung carcinoma, even in the setting of standard chest radiography, as the examiner may be able to identify small tumors that are not evident on radiography. Bronchoscopy can also help to localize the site of bleeding. Here's a chest X-ray showing an antero-posterior view of the chest. The patchy opacities and areas of consolidation are clearly seen. Immediate measures include nursing the patient in an upright position or resuscitation if needed. High flow oxygen may be required. Intubation with an endotracheal tube can protect the airway. Identification and treatment of bleeding include iced saline lavage, topical medications like epinephrine, balloon tamponade, or bronchial blockade, and local thermal ablative therapies. If the patient has a cough that worsens their hemoptysis, then cough suppressants or antitussive medications can be used. The overall goal of treatment is to treat the underlying cause. For example, antibiotics can be administered to prevent infectious complications. This flowchart summarizes the investigation procedure for a case of hemoptysis. Initially, history taking and physical exam have to be done, followed by ruling out other causes that resemble hemoptysis, such as laceration, epistaxis, or hematemesis. Then chest radiography is done. If infiltrations are found, antibiotic therapy is indicated and continuous follow-up is needed. If a mass or other parenchymal disorder are found, then CT scan or bronchoscopy is indicated, and treatment is specific according to diagnosis. Let's end our lecture with a board-style question. A 25-year-old female presents to the emergency department with worsening shortness of breath. Patient was at work when this episode started, and she is very anxious as a result. Patient reports no known past medical history and takes no medications. Her vital signs are significant for a blood pressure of 118/75, heart rate of 125, and respiratory rate of 25. Oxygen saturation is 93%. Physical exam reveals a tall, thin female with long limbs in moderate distress. On auscultation, the left lung field is hyperresonant to percussion. What is the most appropriate management of this patient? A. Albuterol inhaler. B. Chest tube placement. C. Heparin. D. Lorazepam. E. Needle decompression. Or F. Semi-urgent intubation. Alright, so this is a 25-year-old, otherwise healthy female presenting with shortness of breath. Her vital signs are significant for normal blood pressure of 118/75 and tachycardia with the heart rate of 125, and tachypnea with respiratory rate of 25. She has a slightly low oxygen saturation at the level of 93%. For this constellation of findings, the most likely diagnosis is a pneumothorax. Additional findings that support the diagnosis of pneumothorax include the description of the patient having a Marfanoid status and hyperresonance on one side of the lung fields. Marfan syndrome is a connective tissue disorder where patients have an increased rate of pneumothorax. The most appropriate management of a pneumothorax is chest tube placement, so B is correct. A is incorrect. While hyperresonant lungs are common with asthma, it will be bilaterally, not unilaterally. Heparin would be correct if this patient had a pulmonary embolism, which also can present with tachycardia, tachypnea, and hypoxia. However, the hyperresonance and Marfan habitus make pneumothorax more likely, so C is incorrect. This patient's hypoxia is likely the cause of her anxiety, not an underlying psychiatric disorder, so D is incorrect. Needle decompression is indicated in a tension pneumothorax as the most quick and efficient method. This patient does not have a tension pneumothorax, so E is incorrect. While this patient may need intubation at some point, placement of chest tubes improve work of breathing and hypoxia in patients with pneumothorax, so this intervention should be attempted prior to intubation, and F is incorrect. And that concludes this section.